but there's still some exciting data to be shared, and this is the session about metastatic disease, and I will start a treatment on personalized treatment in metastatic non-small cell lung cancer. Now, importantly is what we will not talk about today. We will not talk about chemotherapy. We still do chemotherapy, but there's not much advances there, and there's no reason today to talk about chemotherapy. So we'll talk about personalized treatment and guidelines, and in the guidelines today, and I will not go to the molecular testing, as you heard from Govindan and from Alex Solterman. So let's say we have this patient with adenocarcinoma. We have the extensive molecular analysis. And today, for the three situations, chemotherapy is out and an oral treatment with a tyrosine kinase inhibitor is indicated. This is the case for patients with ALK fusion. Crizotinib is the first-line treatment. For patients with a ROS fusion, Crizotinib is the first-line treatment, or patient with an activating EGFR mutations, where the three agents, gefitinib, Erlotinib, and Afatinib, are the preferred treatment. We heard about the Chinese studies, and I will go here to the non-Chinese studies. This is the URTAC study published by Dr. Rosell. It compares the progression-free survival of a targeted treatment with chemotherapy, and you clearly see the red curve is much better than the blue curve. Now, in the ALK treatment, it is a targeted treatment with crizotinib as compared to chemotherapy. Now, the colors are different, but still, it's the targeted treatment that has a superior progression-free survival. It's an increased response rate, 2 or 3 times as much as with chemotherapy, a longer time until progression, and wherever there is quality of life data, patients prefer the targeted treatment. Now, what those trials have not proven is that there is a survival benefit, and this is largely to the case because the trials were made ethically correct. Patients who have progressed on one arm had the chance to get the targeted treatment. This is the data for ROS1, and this is a very important. You see here the progression-free survival 19 months. We know what the progression-free survival with chemotherapy alone is, 8 to 12 months. But it was only 50 patients, and it's not a randomized study. Why is that? It's a very rare indication, maybe 1% or less of non-small cell lung cancer have a ROS rearrangement, and it's very important. There has been approval of this drug by EMA and FDA just based on a phase 2 trial, and this is really without precedent. There's no randomized trial needed, and it potentially, people think it would be unethical to do that. Now, all this trial, I said, they have not proven of a survival benefit, but the proof came very early from Japan. This is very simple. This is the data on non-small cell lung cancer patients with EGFR mutations from 4 university hospitals. They pulled the data, and they saw, this is the, in yellow here, this is the survival of EGFR mutated patients before gefitinib was introduced. And this was the survival after gefitinib was introduced. It's a doubling of survival. And now, since we know much better on how to deal with those patients, the survival is certainly more than double to that what has been expected with chemotherapy. Now the question is, can one do better? And there has been an important trial from Japan, which said we add, in addition to the targeted treatment with Erlotinib, we add bevacizumab, VEGF inhibition, and there has been good preclinical basis for that combination. And it shows that just the addition of bevacizumab improves the progression-free survival by additional 6 months. In a more complex study, in a one-arm study, we had a BELIEF trial of ETOP, which also has shown that the combination of Erlotinib and bevacizumab had a progression-free survival of 13.8 months, and this is certainly better than the progression-free survival with Erlotinib alone. And based on that, patients treated in Zürich, and I'm sure also in Lausanne, which have an activating EGFR mutations, we treat with a combination of Erlotinib and bevacizumab. Now, I said the survival benefit is not just from giving the drugs, but from learning how to deal with the patients. And what has been very important is the effect of local radiotherapy or local treatment modality. These are patients, 25 patients with ALK or EGFR-driven tumors. They had the first sign of a progression at 9.8 months. These first lesions that were progressed had undergone a local treatment, mostly a radiotherapy, and then they continued the targeted treatment, and it took another 6 months until there was more progression and a need to change the therapy. Well, this is a patient that has been mainly treated by Alessandra. So a male born 1977, an EGFR deletion 19, started on gefitinib and zoledronic acid because of a bone metastasis. You see the response is very nice, but then you see here that he's been more than a year, 1.5 years later on, there is a progression in the lung. What is there to do? Well, of course, you could think of liquid biopsy and radiation, but this was in 2012. I think Matthias was not yet here in 2012. And we wanted to know what is happening with the tissue. So the idea was to undergo surgery to have the progressive lesion removed. It's a treatment and also a diagnostic process. So the patient did have surgery, thoracotomy, but the surgeon stopped then because they saw there were pleural deposits. These deposits were biopsied. It's a relapse, pleural, but it didn't make much sense to do a resection in this case when there is pleural evasion. So then the patient did not have a local treatment, but he was switched to chemotherapy, this is platinum-pemetrexed. I think nowadays we would strongly still consider a local radiotherapy, but that was done at that time. And we'll come back to this patient afterwards. So, despite the great advantages on the oral treatment with tyrosine kinase inhibitors, it's not a curative treatment. Patients live much longer than with chemotherapy, but resistance develops. Now, in the patients treated with EGFR TKIs, 50 to 60% develop resistance because of, we have heard this morning, this mutation T790M, which alters the affinity of ATP as compared to the drug and renders the drug, the tumor resistance to the current agents or the previous agents. Now, I'm still in guidelines because now I'm talking personalized treatment in second line. And already in the ESMO guidelines, personalized treatment in second line is for patients who have an ALK fusion, who progress on Crizotinib, there is Zürich or Alectinib as an alternative. For patients who have progressed on first-line EGFR TKIs and have a documented resistance mutation T790M, Osimertinib is the drug of choice. So patients have the first-line targeted treatment, the second-line targeted treatment, before one even considers chemotherapy. The data about it, here, this is Osimertinib in patients with a resistance mutation, and it has been clearly shown in this New England Journal article that Osimertinib at the time of resistance and the presence of T790M is superior in progression-free survival to chemotherapy. It's particularly also superior with brain metastases, and I have not much time to dwell into that, But in contrast to the first and second generation EGFR TKIs, Osimertinib has a much better brain penetration. Now, why is Osimertinib such an exciting drug? This is kind of the relative efficacy of different drugs. This is mutated EGFR and the standard drug gefitinib, for example. You see there is also some efficacy on the wild type. And the wild type efficacy of the drug is responsible for the side effects, which can be the rash, the diarrhea, other side effects. Now this new drug, Osimertinib, you see, first, it looks like those patients with resistance mutations have even a higher sensitivity to the even previous activating mutations, and there's much less activity to the wild type, so much fewer side effects. So ideally, it's a perfect drug at this situation. Now, this is that patient that will continue the story, and I had to cut it short because the patient was treated by Alessandra, and like we all, she never gives up. So the patient had eventually a progression on the chemotherapy, and then she came to me and says, Rolf, what can I do? I'd like to give carboplatin-paclitaxel bevacizumab after already the patient has this platinum-pemetrexed. I said, this is strange, and she did it, and the patient had a virtually complete remission. So bevacizumab is good for patients with an EGFR mutation. Anyway, eventually the patient progressed, and he had docetaxel, which was not very helpful. And through all that time, Alessandra knew this patient has a T790M mutation, but in Switzerland we had no access to the drug. So what was done? We sent the patient with his agreement to Barcelona. He was treated with Enriqueta Felip, our colleague, in a clinical trial in Barcelona. He received Osimertinib starting in October 2014. You see the CT scan response, very nice response. Also, of course, the well-being, which we cannot see on the CT scan. And so that October 2014 till August 2015, the patient had a profit from this second line, third, fourth, fifth line treatment with Osimertinib. Now then, there was a progression again on lung and bone. It was decided at the tumor board to do radiation, but then the patient had progressed in the liver. A biopsy was done with small cell lung cancer, and at the same time a diagnosis of leptomeningeal disease was made, and the patient eventually died very soon thereafter. But I want to say the diagnosis was in February 2011, and the patient died 5 years later of his metastatic disease. Now we want to do even better. So I told you about the BELIEF trial, which shows a benefit of adding bevacizumab to Erlotinib. We now will start a booster trial. It's Swiss centers like Zürich, Lausanne, St. Gallen, and others will take part. And 2 centers in Korea and 1 in Singapore. And we want to prove or disprove whether the addition of bevacizumab to Osimertinib given in second line further prolongs the progression-free survival. Now let's talk about ALK and second-line treatment. You see here, this is Crizotinib. This is the IC50 of Crizotinib for ALK. The IC50 of Alectinib is superior. The IC50 of Ceritinib is superior. And you see also that these other ALK inhibitors have activity to RET or to ROS1. And I'll come to that later. But the fact is, there is clear evidence that patients who progress on Crizotinib benefit from the second-line EGFR TKI. I have here just examples of a clinical study. Alectinib phase 2 trial, response rate 48%. Again, a median progression-free survival of 8.1 months. We have here a randomized trial, Ceritinib versus chemotherapy, so progression of disease, chemo or targeted treatment, and you see here a response rate of 45% versus 8% with chemotherapy, and of course a much superior progression-free survival. So this is exciting, but there is even more exciting data. And before I go that, I'll go to this panel. In addition to the 3 drugs I mentioned, there is already Crizotinib and Erlotinib, also ALK inhibitors. You may think, like, is it crazy for a rare disease to have so many agents? However, these are looking at different resistance mutations. So in contrast to the EGFR, where there is a dominant resistant mutation T790M, there's a variety of resistance mutations with ALK inhibitors. And I bet in the not so near future, you will have the blood, you do the liquid biopsy, you will determine which is the resistance mutation, and then you have, hopefully by that time, available and approved 4 second-line drugs, and you can choose the right drug for the right patient. But it may even be much later on, because there is data from Japan. And there is a global trial where Oncology is a co-PI, which looks at Alectinib, a second-generation ALK inhibitor, versus Crizotinib. And you look here, medium PFS not reached with Alectinib. It is 20 months or more. And you see the data are in keep with the previous data with Crizotinib. So it's very likely to us that the first-line treatment may be changing to, if societies can afford it, may be changing to Alectinib first, and it may take 2 years until a next second-generation inhibitor will have to be given. In particular, there's also much less side effects with this agent, plus the agent is effective in brain metastases, and brain metastases is the major problem in patients with ALK-driven tumors. So now we go beyond guidelines. TKIs in later line beyond mutated EGFR, ALK, and ROS. So this is what we have available here, and I will mention, except for Entrectinib of time reasons, and we don't have access to the drug here, there is options for HER2 mutations, Afatinib, MET exon 14 skip mutation, Crizotinib, BRAF inhibitors and MEK inhibitors for BRAF mutations. TDM1, we have a study for HER2 amplification, again Crizotinib for MET amplification. And this is only a selection of the drug. Those that we have access here, our patients have, we can provide access to our patients. So let's go first for MET amplification. MET amplification is not an easy determined issue because the experts are not quite in agreement what is an amplification and what not. But it has not been published, unfortunately, but it's been presented repeatedly that high MET amplification patients have a response, this is a waterfall plot, to Crizotinib. And we have used that for our patients. I cannot show all the cases with quite success. MET exon 14 skip mutation. This is an interesting mutation which prolongs the stability of MET in the cell and thus provides more activity of MET. And this is not just lung adenocarcinomas, but it's also found in other neoplasm, including small cell lung cancer. Now, this is a patient that had stage 3B adenocarcinoma. He was treated with cisplatin docetaxel, followed by resection. Then he developed a solitary brain metastasis. He had SBRT to the tumor bed of the brain. He then developed carcinomatous meningitis. And then again, this was treated with whole brain radiation. He developed spinal metastasis treated with radiation. But at some point, the mutation panel was done and it was exon 14 skip mutation. The patient was treated with Crizotinib, and you see the results. Now, unfortunately, the patient could not profit for long because he ultimately died of progressive CNS disease. And we know crizotinib is not such good in penetration for the CNS. But there is certainly an area of, this is certainly a great thing if you see just an objective response on the PET-CT. RET rearrangements, this was first demonstrated in a cell line 2011. And we already have several trials. Vandetanib, Levantinib has been examined for patients with RET rearrangements. And what these trials teach us, not all oncogenic driver mutations seem to have the same potential to provide benefit to the patient. This response rate is not as high as we would expect with ALK or EGFR, and the progression-free survival is not as long. Well, is that based on the molecular characteristics of the disease, or is the drug not the right drug? And we feel that Alectinib would be the best drug for these situations, and we designed a clinical trial. This is now a straight phase 2 trial because it's a rare indication, treating patients with RET-positive adenocarcinoma with Alectinib. This is now under negotiation for the final support. HER2 mutation and HER2 amplifications are different topics for lung cancer. It's not the same. And we had a trial for HER2 mutated patients from ETOP with Afatinib, which is now being analyzed. And we have a trial that is Solange and I are co-PI, HER2 lung with TDM1, what we use in breast cancer. And this trial has also close to accrual and is currently being analyzed. So by the end of this year, we will have the data to share on HER2. BRAF, as you know, is the major driving mutation, BRAF V600E in melanoma. BRAF mutations occur in non-small cell lung cancer. Only about 50% are of this kind of nature, and has been shown in a basket trial, in a specific trial, that BRAF inhibitors have a good response rate. I mean, good is certainly as good as chemotherapy for patients with BRAF mutations. Now, however, as in melanoma, there is, of course, escape mechanism through MET, and then that's why a combination of dabrafenib and trametinib, a BRAF and a MEK inhibitor, is likely to provide a better benefit. And this was presented by a colleague from Paris at ASCO, which see a response rate of 63%, almost as good as with ALK targeting, and you see a progression-free survival again of 9.7 months by investigator assessed. Now this is a lady that is in my care. She is born 1941. She has a V600E BRAF mutations with multiple pulmonary and bone metastases. So she presented in December of 12 and had wedge resections of the right upper lobe and right middle lobe. She had several small lesions that could not be otherwise diagnosed, and it was then the diagnosis as I have spelled out here. The treatment was carboplatin-pemetrexed and pemetrexed maintenance, very good response, partial remission, but after a year the lady had enough of pemetrexed and we stopped the treatment. A few months later, quite a while later, so again I want to say this is not an aggressive disease in this lady. Quite a while later, she had progression and she was then treated with carboplatin and pemetrexed because of pulmonary progression. Only 1.5 times we had to stop. She had severe allergic reaction to pemetrexed, and there's no way she wanted to continue. And then we observed, and at one time one of those lung lesions increased in size, and I asked Matthias, and the patient had SBRT to this lung lesion. But all this time, this was several nodes in the lung. This is just an example that grew and grew. But the patient was feeling fine. But in January of last year, I was not feeling comfortable anymore, and I offered the lady a treatment, dabrafenib and trametinib. She had this treatment. She has a very good partial response, an ongoing response now since January of this year. She tolerates the treatment very well. There's no major side effects. So, the targeted therapy in non-squamous cell lung cancer, that's not deprived, or that is approved treatments in 2017. I've told you what is the approved treatment in first line. I told you what is the approved treatment in second line. I told you that patients that come to us, and I'm sure also to Solange, has many more options for other rare mutations, and we do the best, we try the best to make it available to our patients. But then, of course, then we'll go to the next talk. This year, we will have an approved treatment for pembrolizumab in first line, and Solange will talk about that. But that is all kind of a personalized treatment because it's based on a test as Alex Solterman talked this morning. Now, for second-line treatment, there is other options for our patients. But we have to say, so far it looks like, at least for patients with EGFR mutations, these are the non-smokers, low mutation burden, as Govindan showed this morning, and they seem not to profit as well as from immunotherapy as the other tumors. With this, I want to close and thank you for the attention.